this is where we bring together all the really interesting stuff that we've talked about so far over the previous sessions and try and synthesize it all together. And we have a crack panel of experts here to guide us through it today. So I'm going to introduce you to them very briefly. On the left, we have Dr. Ronan Fawsitt, who is a GP in Kilkenny and a member of the Sláintecare RHA advisory group. So he knows just as much about RHAs as pretty much anyone else in the room. And he is legendary in certainly GP circles for the relationship that the GPs in Kilkenny created with the medical assessment unit in St. Luke's Hospital, to which we all would love to aspire. And to the best of my knowledge, doesn't exist in many other places. Certainly, the relationship I have with my hospitals is appalling. So anyway, enough about that. And next to Ronan is Susie Birney, who is from the Irish Coalition for People Living with Obesity. And then we have Martina Queally, who is the Chief Officer of Community Healthcare East in the HSE, and also my boss. One of my other roles, I am a GP lead and in CH East. And last but not least, I'm going to step back and not break my neck, is Susan Kent, who is an Associate Professor of Nursing, Midwifery, Public and Community Health in DCU, amongst 17 other titles that I haven't got time to go through. So that is our panel today. And what I thought we might do first of all, and we are talking about what changes are needed to integrate services at the front line. I'm going to get away from the speaker. So I thought we might just let each of our panelists just have a quick minute or two about their random bullet point thoughts about what changes are needed to integrate services in the front line. Ronan, will you kick us off?
Well, it's thank you for that. It's really interesting to see what the themes were today, and the resonance was huge for me as a GP of 40 years. It was all about trust and relationships and about connections and communication, the very simple things, the ingredients that make healthcare work. And I'm a great passionate believer in Sláintecare and integrating health. It was great to see Sarah talk earlier, and it's great to have Professor Gary Courtney in the audience, somebody I've worked with over many years that are in our local situation. Integrated care is a journey, it's not a destination. It's never going to be perfect. And by the time we've done our 10 years, they'll want to change it again. And that's fine. But it's about connecting the dots. But to connect the dots, you've got to have the right dots, and you have to have enough of them, and that's staff. And the dots must communicate with each other. And that's every talk has been about doing that. So from my mind, what is Sláintecare? Right care, right place, right time. That's integrated care for me. So to my mind, having been involved with Gary and the GPs in Carlow Kilkenny over the years, the first thing we had to do was sit down and talk to each other. And that's probably the most important thing that we need to do in the health service and in the RHAs, is create a culture where people can talk to each other. But there are three parts to this RHA puzzle that we need to embrace. One is we've got to get ICT done. Bring back Boris. Get Brexit done, get ICT done. Because we have 500 a day waiting to get into hospitals. We have 1 million on waiting lists. We have a problem of connectivity. And we need to fix it, and it is fixable. We live in a digital revolution. We need summary care records. Professor Emma Wallace of UCC on an ICPO webinar last week, 1,000 GPs in the room, said summary medication record would be a game changer for healthcare. And it's as simple as that. So we've got to embrace the digital piece fully and get it done. We've also got to get the right manpower. Our LICC local integrated care meeting last week, 2 weeks ago, was all about the absence or the deficit of home care attendants. So our hospital is caught because there aren't enough home care attendants to discharge into the community. So it's integrated care is a jigsaw. It's about the front door of the hospital and the back door of the hospital, and the back door of the hospital is where they come back to. I give a lend of my patients to Gary for a week, but they come back to me. I am vested in their care. Front door, back door of the hospital is the key interface that we need to get right. So the right manpower, the right IT, get it done. But the key thing to me is changing the culture. change the culture around talking to each other. We need to do that. GPs, consultants, managers, allied health professionals, nurses need to have a forum to communicate at a local level. If we want RHAs to be different, they've got to behave differently and they've got to empower people differently. And that means allowing everybody at a local level to have a voice, to participate. And I know from our journey over 25 years or more with our local group in Carlow, Kilkenny, and please, it is Carlow, Kilkenny. Always remember Carlow. It's 2 counties, GPs and hospital. It's been a journey, and we're all on side. We need, if the RHAs are going to succeed, they need to create a structure and a culture of engagement and dialogue at a local level between GPs, hospitals, nurses, whatever. And in that process of talking, they will then build the trust, build the connectivity, begin to try things, see what works. And that has been our pattern. We started with our journey many years ago with opening the AMAU, which was the first in Ireland. And GPs had to give up their visitation rights or their admission rights to hospital to get a better service for their patients, but we did. And over the years, we've worked on streaming patients to the right doctor from the community. So they go directly to an ASAU or a surgeon. They go directly to PEDS. They go directly to OBS. They go directly to psych. ED is a very valuable piece in our structure, but ED is not where you send everything to. And that process of engagement has allowed the care pathways to develop. So I think there's a real opportunity for RHAs in the next while to embrace that and to create a structure, some regional integrated care process to allow everybody to talk to each other at a human level. Because what I was picking up on from the last talk was the importance of the human dimension in healthcare. So they're the 3 things that I think are really critical.
Excellent. Thank you very much, Ronan. I don't think I'm certainly not going to disagree with any of that. And yeah, we're all still in awe of your pathways to care, whereas the rest of us just have an ED and that's it, and it's not good enough. Okay, next we're going to get a view from a different corner of the universe from the patient's point of view. So I'm very happy and delighted to have Susie Birney with us. I think as a health service, as clinicians, we don't interact enough with patients and patient representatives in terms of influencing policy and decisions. So we'd like to have you with us here today, Susie. Do you want to give us your thoughts on how to integrate services properly?
I have to say I've rewritten my notes about 3 times from what I've heard this morning, so I may deviate from my 3 points, so apologies in advance. Individualised care, I think for us as people who live with this experience, and we say live with, not battling or struggling with, we live with this, whatever chronic disease we have every day. And I think it's to stop the silos and break outside of, like for myself, I'll give you my own example. I attended the weight management service in Dublin for my obesity. I attended Beaumont Hospital for my diabetes, and I attended the Women's Health Clinic for my polycystic ovarian syndrome in Cahal Street. Never knew any of that was connected. Never knew the connection between all of those health issues. But what I heard earlier from Brian, the first speaker, was about giving patients back their time. When you live with obesity, everything takes longer to do, whether it's even just showering, getting dressed, getting up, getting to your appointment. And that takes a huge amount out of your time. And if you imagine then going into, then I have diabetes appointments, and you go for your weight management appointment and you have to do blood tests, and 2 weeks later you're asked to do blood tests for your diabetes. They're not connected. And to me it just seems absolutely ludicrous and quite disappointing in a way for me to hear that'll be 2030 before patients can access digital care, because that's 7 years away. I'd love to see that change happen next year. I think it's really important, and I'm fascinated by all the discussions on this. Patient-centric co-creation, these aren't just buzzwords. These are actions that need to be done. Putting patients at the centre of what you're doing is really, really important. And I think that we have a very good example of that in obesity, and that we have worked with the Association for the Studies of Obesity Ireland since 2016. I'm a patient representative with them that length of time. And I actually sit on all the HSE committees with some members from ICPO, and we're part of the very start of the process. I went for a training recently in Milan with the Global Heart Hub about health technology assessments. I didn't have a clue what I was walking into. I knew very little about health technology assessments. And there was a lot of organisations there. There was heart valve, all cardiovascular disease, even kidney patients. There was a range of people there out of the 60 that were attending. And they asked at one point, hands up anybody who has been involved in a health technology assessment as a patient. And I put my hand up thinking loads of people would. And I was the only one in the room. So we are ahead in some ways with patient engagement, but we need it not to be as tokenism, which quite often it can be. And that's our job to make sure that that doesn't happen. I saw on Ronan's slide earlier about the chronic diseases, and I saw that obesity isn't there. Why? Why, when it's so connected for chronic disease management, if we're going to integrate, we have to recognise that obesity is a chronic relapsing disease as well as all the others. Because if we don't merge these and see beyond just this disease management, we're not going to integrate at all. Hands up who knows in this room that there is actually clinical practice guidelines just released for obesity. Okay, not even half. Well, that's my job done, I can go now. You now all know that there are new clinical practice guidelines for obesity. And this is something that was said to us, is that here in Ireland we are great at writing documents but not great at implementing them. And that, I think, is something that's really important to take away from today. This man here asked a very good question. How do we measure success? For us, we know in ICPO that there are huge improvements, that there's a new model of care, that there's new clinical practice guidelines, but our patients don't know because they're still getting letters being referred to the Dublin Weight Management Service saying that there's a 5-year waiting list. When is that going to trickle down? When is that going to come through to the patient who's needing that care? And I think that's important that we know that. For us, treatment is prevention. Because when you treat obesity, you're treating everything else that comes with obesity, and that is important that we don't lose that sight. And my third point, which I will try and cover my 3 points, waiting lists aren't the only barriers. For us, it's stigma. And stigma that, when it was asked earlier on the panel discussion, I would have loved to have hopped in there, about who has had good care. Well, unfortunately, in obesity, quite a lot of patients haven't had good care, and a lot of it comes from their healthcare provider with stigma and stigmatising attitudes. And the Action IO studies, which was 11,000 people from across 6 countries, showed that patients don't go back for treatment for 6 years after they've had one bad encounter with stigma. 6 years, you imagine what's occurring in that 6 years for that patient. And this is really important for us to address. In ICPO, 2 years ago, a researcher published her paper, and one of the lines on it was that 55% of physical therapy students would not work with people living with obesity because they've no willpower. So it was published, and then there was nothing, and we said, okay, but what now? What's next? So we created a committee with 6 people, the researcher involved, ourselves, ICPO, and now 2 years later, we have 20 people representing all the multidisciplinary team, representing most of the major colleges, and we this year we have 8 stigma education talks lined up for the next 5 weeks, where we do stigma talks with healthcare students, and our bigger aim is that we will have stigma education put on all healthcare curriculum, but the smaller aim is that we run these stigma education courses for these healthcare students who are going out to work with what is 60% of the population who live with overweight or obesity. So we need to address that there are more barriers than just waiting lists, and in integrating care, we need to look at the bigger picture. One last thing I'll just say is that quite often, the lady earlier said about being, sorry yourself, I'm named, so I'm gone. I'm nervous and that's why I have my tissue. About being in this bubble. And we come to these conferences and we're in a bubble. You're investing this is your job, this is what you do. When you go outside of this bubble, what happens? Where are we trickling out this information beyond where we're sitting here? So we can all sit here today and say, oh no, that's terrible. Like myself, 7 years before digital technology is going to kick off, I was disappointed. But I don't want to walk out of here thinking what's not being done. I want to walk out inspired what is going to get done. What action can you take today when you walk out of here? That's me.
Brilliant. Well done, Susie. Yeah, very well said. Next, we have Martina Queally from Community Healthcare East from the HSE. Martina, give us your take on things.
Okay, thanks very much. I was relieved when I didn't have to do a PowerPoint, and then I tried
if you want.
I tried to put it all into 3 bullet points, and that was really difficult. And I didn't talk to Ronan before, just in case anyone thinks I did. I had no consultation with him. But there was 3 things, I guess, that just from my own experience, I think are critical to a success in terms of Sláintecare. And one is effective leadership, and I don't mean just a person at the top, I mean dispersed leadership and clinical leadership within our teams. And I think from my own experience, where we get true magic is really where we get that kind of dispersed leadership and that empowerment of people in the system. So that's the first thing I think is, and it touches on culture, it also touches on that freedom to be able to develop structures and systems that you know are required for the delivery. The second part is around this. Now, this is probably I hear people saying all the time, oh, the structure isn't important. I actually think it is. So I'm going to go a bit counter to what you hear in the system. My experience and I've managed fairly large organizations, and my experience is that human nature loves a pattern. And when you have good structural alignment and organisation, people do better. They love to be able to recognise a pattern. A lot of the conversations Ronan referred to, they happen better when you have a pattern in the system. And even for me, in the management of some of the systems that I've managed, it's easier when you have a good alignment and pattern if you want to take corrective action. So whether it's fostering it to do better or to have that kind of dispersed leadership, or indeed to take corrective action, my experience is for governance and organisation, structure does matter. And I think when we talk about stepped models of care, I think they're one of the secrets to success. Because right now it's a bit like having the ladder up against the wall to reach something as a patient, and when you get to the top you can't get back down, or there's rungs missing on your way up, or it goes nowhere actually, the ladder, which is unfortunately the case at times as well. So when we talk about stepped models of care and integration, I think we need to have really clear pathways of care. And we've done some lovely work through the ECC programme on older persons and chronic disease. Now, they're only in their infancy, but they do demonstrate where our gaps are and where we need to really lean in to those very good stepped models of care, where patients don't need a compass every time they set about trying to find the right treatment, that it's very clearly signposted. Just in terms of Sláintecare, and there's like millions of papers on this, and the earlier speaker said it as well in terms of integration, and we've borrowed a lot from horizontal and vertical integration from commercial sector and private sector. And I think some of the Australian papers actually are really interesting in looking at that differently in a health service, borrowing from the commercial, but looking at it from a health service perspective in terms of horizontal integration, particularly in terms of avoidable or preventable disease, and looking at what I would call radical interdependence. Those kind of partnerships that you don't automatically recognise, but we saw come into their own, particularly during COVID, where all bets were off and we could actually partner in anything that was effective. And we saw that kind of radical integration really come to the fore. Now, I think if we want to particularly address inequalities in health, we're going to have to really look at that horizontal integration. To really understand our populations and what structural barriers exist that determine the health of some of those subpopulations. And finally, to fill you full of hope, the IT strategy. We've seen that in the early work we've done around ECC, that referral comes by carrier pigeon sometimes, and sticky notes and telephone and fax and letter and whatever way they come. Fragmented IT systems are problematic, to say the least. They are not just a nice to have, they're an absolute enabler in terms of integrated care. So truly a good IT strategy, to my mind, is critical to success.
Brilliant, thank you very much. It's great to hear people talking about Australian models for a change. We've had Dutch models for the last few years. Now we get Australian models, which is great. It used to be an Australian model, but that's a different story. Now, Susan, will you finish off the sweep of the panel for us?
Sweep of the panel, and basically, honestly, you're going to hear not repetition, but a different interpretation of what's been said in a different space, okay? I suppose I've got a long track record as well of being from practice in acute and community services to policy to corporate to academics, all right? So I do speak with different hats on me and collectively with the hats as such. So based upon evidence and also experience, I'd like to give you my sort of view of the world. I was also had the privilege in the Department of Health to be involved in the development of the Sláintecare action plan, particularly related to community-based care. And it's a wonderful, a whole wonderful plan, of course, because I was involved. But the point is, though, it is still a strategy. It hasn't been executed in its full potential, but it will be great when it happens. I suppose with all of the hats that I wear, I would like to offer to you three sort of point plan that I would see that would operationalise or solution some of the integrated issues that are identified in the front line. And the first one I would like to say to you is that obviously we know that one of the biggest problems we have is the workforce supply, okay? What we do know is that right now in Ireland, we are set up, our systems are set up in such a way as to direct an awful lot of our population to either the GP or to the hospital, and that's absolutely causing a system overload, as you're all aware of, okay? So what I would say is that the main problem here is, honestly, and it's been mentioned before, Sarah's really done it in the morning session, and I think she looked at my notes anyway. So, and I would honestly say that we have not got access to healthcare in a timely fashion. And that's why we have health insurance, we buy it, okay? So we don't have access to healthcare, right? So then you've got to say, what's the root cause of all of that? We've a labour shortage, okay? So then the next thing you would say to all of that is, well, we have tried to solution that. We increase the pay, we're doing the contracts, we're increasing jobs, but that's not kind of working, you know, sort of thing. So what I would suggest is that we need to really sort of look about buffering the workload of the GP and the HSE, the hospitals, I mean, by actually getting engaged in some workforce diversification, all right? But now that alone is not going to cover it won't cover all of the aspects of healthcare, and that leads me to my second point, which is we need to really, really redesign how it is that we access healthcare, okay? The way we are at the moment, right here, right now, we currently funnel a lot of our work to the GP or to the hospital, and the people themselves will walk with their feet anyway to where they want to go. What I would want to say to you, and it's taken on Martina's ladder, okay? That's offering 2 points on a vertical sort of line, okay, that needs to be really stretched out. But if I do take Martina's ladder, I would say that we only have 2 rungs on it. We've GP and we've hospital, okay? What we really need to do is to support the GP and hospital by actually putting more rungs on, diversifying the workforce, allowing nurses and other health professionals to maximise their capability to their scope of practice. It doesn't matter if it's an RGN nurse or if it's a nurse practitioner. They can all work to their scope of practice. It's the same with the physio and likewise, okay? But what you will get when you start to do that, you will get an attraction to work in that particular area. You'll then get auto-scaling, okay, which will share out the patient load for everybody. So if you increase the rungs on the ladder here, okay, that will result in relieving the burden for GP and hospitals by reducing the volume factor, okay, which also equals to increasing the labour attraction. Now that sort of vertical integration, you will not be able to maximise the capability of any professional, and we very much know this in the community space, unless you remove the barriers. You've got to remove the barriers so that the referral pathways into the system, out of the system, and that. It can't be very hierarchical and it can't be professionally centric. It has to be governed, but it can't be owned by one profession either. Okay, if I was to sort of say to you, I was driving and thinking about this in the past few weeks and saw a crash, right? And I thought to myself, well, the health service at the moment is like a car heading into a car crash. And what does it have for safety? It has seat belts and it has a brake, okay? What I'm sort of saying is I want to buffer all of that safety. The seatbelt on the brake is the GP in hospital. You want to buffer that, right? So what do? I'm going to introduce airbags, sensors and sidebars, all right? So I'm going to make a super effective car. So really at the moment the HSE is like offering seatbelts and brakes, but really what we need is airbags sort of and other stuff. But what we also need to do is to retune the population and the policy makers to understand that not everybody needs a doctor or a hospital, okay? And that leads me to my point 3, and it's an old point, okay? Point 3 is really where we need to reinforce navigation of healthcare and coordination of healthcare. If you were to look at integrated care, there's a bit of a misnomer. Everybody thinks it's bringing acute and community together and joining them up, okay? Integrated care is actually care of a person, wherever that person is, okay? It's ensuring that they get what they need, not what the service can offer, all right? And I would say that if we got people into the service through access, then if we assisted them in navigating the care, bearing in mind they may not need a doctor or a hospital, and then when they do receive care, that we coordinate that care regardless of where the care is delivered. Honestly, if we want to understand the patient journey, yeah, we need this would help to avoid duplication, but most importantly, it would avoid miscare. And all of this can only be enabled, as everybody has said before me, with a digital platform. So thank you very
Brilliant.
much.
Thank you very much, Susan. So, there's 4 perspectives. Now, you know, if I was running this conference, I'd have given them each of them their own slot because there's 4 really interesting perspectives on a problem that we're all up against. I'm going to open the floor to questions because I'm sure there's lots of them, but while I'm doing it, there's a comment come through referencing your comments, Ronan. You spoke to manpower in general practice. This means drawing GPs and GP nurses into the primary care fold in terms of communication and cooperation. Integrated care needs to bring together all professionals, talking together, learning together, and from one another. Now, who has a question, and who do they want to ask it to? Don't be shy. We've got time to really get stuck into the meat of it. Yes, this lady. Just hang on there for a sec. Hillary, bring you your microphone.
Where does the sort of, in the UK they've introduced this virtual wards and sort of patients looking after themselves. Where does that self-care piece fit into your integrated care models and theories?
Care for chronic disease, there are elements of self-care right along that stepped model of care. But equally, I think there is very significant work that has to be done in the area of prevention and really understanding those determinants of health. So that, and like to speak to Susan's point, I think there's a real risk of blame sometimes when it comes to prevention and ill health. And that's never constructive, actually. Either in management or in self-care. Blame is rarely effective. So understanding and having good conversations and in that spirit of cooperative inquiry is always much more effective in my experience. So I think, and to speak to the point I think earlier in the conversation around ICT technology around mental health, obviously prevention is hugely important. And I don't think they're all or nothing approaches. I think some of that technology will work really well for certain segments of the population, and for others it won't. So it should be part and parcel of the offering right through our system, to be constantly looking at how we can encourage self-care and promotion. Yeah.
I worry there's a fine line there, though, because particularly with obesity, self-care, it's all about blame. And I don't think there is one person who lives with excess weight who has not tried and tested multiple methods of trying to self-care. And I've lost and gained 3, 4, 5, 6 stone 10 times in my lifetime. I weighed 25 stone. I had bariatric surgery. I weighed 11 stone. I'm now in the middle at my best weight. I'm maintaining with further treatment. But I spent many years blaming myself and trying everything to self-care, but yet people saying to me, you need to do something yourself.
Yeah.
My own GP does not believe obesity is a chronic relapsing disease, and he said to me, oh no, that takes away personal responsibility. He knows what he's referred me for. He knows I've taken... I had a quick look, he's not in the room. He knows what I have done in my lifetime to try and take responsibility solely, actually, with, you know, him referring me. But so But
I mean, like, that's a good example, because I mean, the emerging evidence around overweight and obesity is, you know, very interesting in terms of root cause and you know, and correction and modalities for correction. So I think that you know, I would agree with you. I think we need to be very careful. I mean, I think sometimes, you know, when you look at disadvantaged populations, the same blame arises where people say, well, they just did things differently, and we know that's not the case. There's no evidence for that.
No.
You know, there's evidence for a lot of systematic and barriers for disadvantaged populations in terms of the determinants of health, and they're very clear. I think the cancer research just launched earlier this week again showed that very significant disparity in terms of health outcomes. So it is really important that we look at and this is a unique opportunity in Sláintecare for that geographic alignment to look at some of those broad determinants of health.
I think we should say that actually there were some patients do want to look after themselves with a bit more knowledge.
Yeah.
I had personal experience that with a family member, but it's getting, where's the access point to that information?
That's it, yeah.
This goes back to Martina's point and your point about vertical and horizontal integration. If we're going to provide healthcare, there's 4 pillars to it. There's self-care, and we need to maximise that. We need to maximise the prevention. This makes common sense. But we also need to maximise people like Susie, who brings a group thinking, a dynamic, an organisation, an NGO into the mix, brings a community resource, which is within kind of the primary system, but it's allied. So you've got self-care, we've got to maximise what Susie brings, because there's tremendous wisdom in what she's saying. And there are many other organisations, the Asthma Society, whatever, who bring something to the table of care. But then you've got primary care and secondary care. And the purpose of primary care is not to look after the hospitals. The purpose of hospitals is to look after primary care. And tertiary care is to look after what secondary care can't manage. And we need to maximise what's done in hospitals, and only what should be done in hospitals should be done in hospitals, because our mindset is healthcare equals hospitals, and it isn't. We all know that. We've got to maximise what we do in general practice, but we can't sink the ship, because when the under 6s came in, it overloaded us for a year or two, and we nearly sank. I know from my own personal experience that I went from seeing nearly 40 people a day to 50 people a day, and it wasn't safe. I remember having a conversation with Tony O'Brien about that at the time, that while under 6s is desirable and it's a good thing, we didn't plan enough for it. We weren't prepared. So when you introduce change, when you shift care out of the hospitals into the community must be ready. General practice needs to be resourced to actually provide care.
Could I just add on to Ronan's piece as well? I mean, like, if you were looking to actually be dynamic and change the way care is being provided or is going to be available, then you have to look at all the options. Martina mentioned the fact that, you know, sort of thing, there was dynamic, innovative sort of buy-in from different services over the COVID. That needs to continue. The whole PCRS system, the system by which services are bought by the HSE, they're fundamentally, they classify them as being across all health professionals, but in actual fact they're for GPs, opticians, dentists and pharmacists. Anybody else that would want to sell their wares to the HSE or you know, aside from a big national contract, you know, the computer says no. So an awful lot of the general managers you speak to, and you're offering a solution that would help maybe in the immediate sort of, like what happened over Christmas and January, you could offer some maybe immediate care outside of the hospital that somebody would traditionally be admitted for. The computer says no. and therefore they're not able to sort of develop the contract with you and pay you accordingly. So there's other innovative ways that you can sort of engage people to provide the services as they are required as well.
Can I just add?
The clock is on you, but go on.
I'd just like to pick up on the points. These are very good. Susan, you mentioned a new definition of integrated care of the individual, right?
Yeah.
But maybe we could add the individual at their home. So in my hospital in St. Luke's, there's 303 beds. 44 of them are psychiatry beds. So we have 260 beds for everything. And the hospitals are being tasked with accepting everything from everywhere all the time. And as Ronan says, that's ridiculous. We should only deal with complex and technological care. Everything else shouldn't be in the hospital. But obviously, Sláintecare, we're going to try to do that. And Susie, you mentioned obesity, right? You spoke really, really honestly about it. And I must say that was very moving. But if the RHS could deal with three things, OSA, obesity, smoking, and alcohol, that will solve our problems. They lead to cancer, they lead to chronic disease. None of those should be presenting through those three conditions. And they're simple to deal with, and they should be dealt with at a community and a GP level. And that's what I'd just like you to focus on, the obesity, smoking, and alcohol. Sort them, and an awful lot of the healthcare problems are solved immediately.
I'd just like to say obesity doesn't lead to disease. Obesity is a chronic relapsing disease that needs to be recognised in its own right, really, really urgently. I could talk for ages on that, but no, when you said about the importance of the patient voice, it is actually quite scary in some of our support groups. Now, we're involved in about 6 different support groups online between Facebook, WhatsApp and whatnot, and there's about 3,000 people. And patients are educating each other in the gaps where they're waiting for their to be signed up for their treatment, and they're on a waiting list and they're in limbo, and they come onto a support group, and quite commonly the comments are, oh, I didn't know that. I didn't know I couldn't take that medicine after surgery. I didn't know I couldn't do this. And they are actually educating each other, and that's actually quite scary. And not to throw out a very huge topic here, but surgery abroad, we are dealing with that in our support groups, with people coming back from having had surgery abroad because they can't get access to treatment, and they're going abroad for it, a lot of them without proper, sort of knowledge and backup, and they don't tell their GP. And we're dealing with that in the support groups of when they come back, but they're landing in the GP's office with these complications too. So we're in a vicious circle. We're in an absolute vicious circle with them.
Excellent. Well, look, I think we're going to draw things to a close there. I thank you so much for your questions. Really quick. These people need to eat.
This one is for Dr. Putting efficiency and effectiveness at the center and heart of the GP practice. What do you think are the high value generating features of a good integrated digital platform that will ensure adoption and speed of access to the GP service?
A good digital platform.
Digital integrated platform.
I would like to get an e-discharge from Professor Courtney's team on a same-day basis. I'd like to have an e-prescribing facility. I'd like to have access to appointments for my patients, not send a letter and hope that they'll get an appointment in 6 months. I want to be able to see on a screen what is the waiting time for my patient to see a surgeon or to see a physician or to see whoever. This isn't rocket science. It's called Health Pathways. It was developed in Canterbury, New Zealand, many years ago. And they put a digital platform together for clinicians, number one, to link the hospital and the community. Then they brought patients into it. And you will know this, Paul, because you're using it in Australia. And it's now being used in the UK, in Tyneside, in Cardiff and Vale. So Health Pathways is a digital solution that I as a GP or Gary as a consultant or a patient can access information on self-care, local community services, and make appointments to see me or to see the nurse or whatever. And it gives information that's up to date about what pathways are available in the community. That's the platform I want. That's what Sláintecare should bring to us. And it's that kind of streamlined process that will help fix things.
Brilliant. Okay, I'm going to interrupt there because we could talk about this all day and it's fascinating. But hopefully you've picked up some little nuggets about integrated care we've heard about how it's being planned and what's going to be happening down the line. But we had a fascinating insight from Yvonne earlier on, and then Helen, and then our first panel with the two Johnnies, and now these four fabulous speakers. Will you thank all of them on